We are diving into one of the most stubborn global health crises there is, chronic joint pain. I mean, if you or someone you know suffers from arthritis, you get it. This isn't just discomfort. It's a real erosion of your quality of life.
It absolutely is.
We're talking about a medical problem affecting, what, something like 1 in 3 people in the United States? And that number is just, it's escalating fast.
It's a silent epidemic, really. And osteoarthritis, or OA, that accounts for more than half of all those chronic joint complaints.
More than half.
Yeah. And here's the critical thing. Due to our aging demographics, the prevalence of OA is projected to increase by at least 50% in just the next 2 decades.
Wow.
So the burden right now is enormous, and the future outlook is, well, it's challenging.
And the standard roadmap for treating this is pretty well known, but it's often so frustrating for patients.
Right.
You start with exercise, self-management, then move to pain relief. But that relief often relies on NSAIDs, which, if you use them chronically, carry pretty significant systemic risks.
Oh, absolutely. We're talking about potential damage to the GI tract, the kidneys, the heart. It's not a benign long-term solution.
And if those fail?
Well, the next step is usually intra-articular injections, but their efficacy often just declines over time.
Right.
And some studies suggest that repeated use can itself lead to potential cartilage loss. So you might be trading short-term relief for long-term issues.
So the final stop is major surgery, joint replacement.
Which is reserved for the most severe cases. You see, there's this huge therapeutic gap right in the middle.
For those millions of patients whose pain it's manageable, but it's refractory. It just won't go away with the usual treatments.
That is the exact patient population our sources are targeting.
And that's where we're introducing this minimally invasive detour, Transarterial Embolization, or TAE.
Today, we are undertaking a deep dive into the current status of TAE, specifically Genicular Artery Embolization, GAE for knee OA. We're drawing heavily on a really comprehensive AJR Expert Panel Narrative review.
So our mission is to unpack the mechanism, its applications, and maybe most importantly, what the latest randomized controlled trials have actually revealed.
Exactly.
Okay, so let's drill right into that core mechanism. I think a lot of people hear knee pain and they think of, grinding cartilage. Yet this procedure involves restricting blood flow. So how does putting tiny particles into blood vessels actually treat chronic joint inflammation and pain?
Well, it fundamentally changes the conversation about what chronic pain is. This procedure targets something called synovial hypervascularity.
Okay.
Think of it this way. Chronic joint inflammation, or synovitis, it triggers the body to try and repair itself. But it does a bad job, leading to what we call neoangiogenesis.
So the growth of new blood vessels.
The chaotic, abnormal growth of tiny new blood vessels right there in the joint lining.
So it's not just that the cartilage is damaged. The joint lining itself is essentially feeding the fire.
Exactly. And these abnormal vessels are the real problem. They produce and deliver all these pro-inflammatory mediators, like cytokines and vascular endothelial growth factor, VEGF.
Which just keeps amplifying the inflammation.
Constantly. But here's the crucial part. This vascular overgrowth, it doesn't happen in a vacuum. It causes the concurrent growth of new unmyelinated nerve fibers.
Wait, hold on. So you're saying the abnormal blood vessels are actually building the physical infrastructure for the nerves to transmit that chronic, painful signal?
That's precisely it. It completely changes how we should view the pathology of chronic pain.
That's a huge shift.
It is. And so TAE intervenes by selectively disrupting the supply chain, by reducing that abnormal blood flow, by, pruning these vessels. We interrupt the inflammatory stimulus and basically starve those newly formed pain nerves.
And this isn't just a theory.
No, not at all. Preclinical studies, including some in rabbit models of OA, confirmed that embolization significantly reduced synovial inflammation and it lowered T-cell markers. It has a powerful anti-inflammatory effect.
Okay, that mechanism, inflammation driving vascularity, which then drives new pain nerves, that's crystal clear. Let's talk about the biggest clinical application, GAE for the knee.
Right.
Given the huge prevalence of knee OA globally, who is the ideal candidate for this pretty precise technical procedure right now?
Patient selection is everything. It really is, because we know this isn't for everyone. Currently, it's strictly limited to patients with mild to moderate knee OA pain.
And it has to be pain that's been refractory to conservative treatments for at least 3 months.
For at least 3 months, correct.
And just as important, who do they exclude?
Patients with the most severe disease. Those who are classified as Kellgren-Lawrence or KL grade 4, they're generally excluded.
Why is that?
Statistically, they're just far less likely to achieve a positive lasting pain relief. Their damage has likely progressed beyond the point where just managing the vascular inflammation can help.
So how do you quantify refractory pain to see if someone is eligible?
They use objective, validated metrics.
Yeah.
The visual analog score, or VAS, is common.
Right, on a scale of 1 to 10.
Yeah, often requiring a baseline score greater than 5 out of 10. And they also rely on these detailed questionnaires like WOEMAC and
Those are so important because they don't just measure pain, right?
No, not at all. They measure physical function, stiffness, the patient's ability to engage in activities of daily living. They measure the toll the pain actually takes on your life.
Okay, so if the challenge is finding and treating those hypervascular spots, the knee's arterial network, I mean, that sounds like a real minefield.
It requires extreme anatomical precision. The knee is supplied by this dense network from the popliteal artery branches. That's the superior, inferior, medial, and lateral genicular arteries.
And then there are others too.
And also branches of the superficial femoral artery, most notably the descending genicular artery, or DGA.
And the DGA seems to be a key player here.
It is. It's the most commonly treated vessel.
And why is that?
Because the medial compartment of the knee is the primary site of that weight-bearing inflammation, and it's largely supplied by the DGA, the SMGA, and the INZA. But, and this is important, anatomical variations are really common. Sometimes the origin of these vessels is at a really acute, difficult angle for a direct catheter approach from the typical femoral artery access point.
So the technical challenge forces them to get creative with how they even get in there.
Absolutely. If the femoral approach is too challenging, the procedural expert might have to switch access entirely, maybe using a tiny distant entry point like the pedal or tibial artery, which lets them navigate upstream to reach the target.
Let's talk about the micro-level procedure. What happens once they're inside the target vessel? How do they actually do the embolization?
So the procedure starts with ultrasound guidance to access the artery. Then they thread a microcatheter, which is this incredibly small, flexible tube.
How small are we talking?
We're talking 1.7 to 2.4 French. I mean, it's barely thicker than a piece of hair. Once the tip is precisely positioned, they confirm the hypervascularity with an angiogram, and then they deliver the embolic agents.
What are these agents? Are they designed to create like a permanent blockage?
Not a permanent blockage, but a permanent pruning of that abnormal segment. The agents are generally microspheres, typically 100 to 300 micrometers in size.
Okay.
And the literature shows successful outcomes using two main types: temporary agents, like an IPM-CS mixture, and permanent agents, like embozine microspheres, which are more common in U.S. and European studies.
Both seem to work.
Both seem to achieve the desired clinical endpoint: a significant reduction, but not a total obliteration of that abnormal vasculature.
That makes sense. You don't want to kill the entire artery, just the pathological offshoots.
Exactly.
All right, now for the payoff. What did that initial efficacy data look like?
Well, the early results generated significant buzz. A 2017 study, the largest cohort to date, reported a massive 79% reduction in WOMAC scores at 24 months for patients with mild to moderate OA. 79%. That's a huge improvement in pain, stiffness, and function from one single, minimally invasive procedure.
It is. And improvements typically peak between 1 and 4 months after the procedure.
Okay, but hold on. If those initial long-term results were that massive, a 79% reduction, why are we still so strict about excluding the severe OA patients?
It was confirmed in later research. One study found that while the mild to moderate group maintained that excellent long-term relief,
The severe group didn't.
the subgroup with severe KL grade 4 OA, they did get some initial pain reduction, but that pain quickly rebounded right back to baseline by 6 months.
So the structural damage is just too advanced.
Exactly. The vascular targeting alone can't sustain the relief.
Okay, this is where we get to the critical proof point: the randomized controlled trials, the RCTs, comparing GAE against a sham procedure. Because often, the excitement around a new technique gets tempered once you account for the placebo effect. What did the first big RCT reveal? Right, that was the Bogla study, the first sham-controlled trial. They found significant improvements in the treatment group compared to the sham group.
Which is what you want to see.
And importantly, when they crossed the sham group over to receive the actual GAE procedure, those patients also achieved the same benefit.
So that validated that the procedure itself was working. It's not just placebo.
It showed it was better than nothing.
Yeah.
But there's a really crucial insight from a more recent RCT, the Landers trial in 2023, that, well, it fundamentally changes how we think about standardizing the procedure.
Okay.
So Landers initially found no overall difference between the GAE group and the control group.
Oh, that's a serious finding. That could have derailed the whole thing.
It could have, but they didn't stop there. They performed a meticulous subgroup analysis.
And the aha moment was what?
It was all technical. They discovered that only the patients who received complete multivessel embolization, meaning the operator went after every single hypervascular vessel they identified, only that group had significantly improved outcomes, particularly in activities of daily living and overall quality of life compared to the control group.
Wait a minute. So the difference between success and failure wasn't the patient or the agent, but the completeness of the intervention.
Precisely.
This means partial treatments are essentially useless. That drastically changes the training and the approach needed.
It points right back to the mechanism. If the entire synovial lining is hypervascular, only partially pruning it leaves enough infrastructure intact to keep feeding that inflammatory cycle and that painful nerve growth.
If you want to disrupt the pain signal, you have to be comprehensive.
It elevates the importance of anatomical precision from just being beneficial to being absolutely critical for clinical success.
That is a massive finding for standardization. Okay, let's quickly touch on safety. For any arterial procedure, people assume the risks are high. What did the review find?
You know, GAE has proven to be remarkably safe and well tolerated. Yeah. The most common adverse event is actually pretty minor. Temporary skin discoloration over the knee.
And you can minimize that?
You can. Clinicians use an ice pack during the procedure to tighten those surface cutaneous vessels. Serious complications are rare, things like small, asymptomatic bone infarcts, and some reports of transient numbness in the foot.
And they know what causes that.
It's often associated with extremely aggressive embolization or using the very smallest 75 micrometer particles.
Okay, so GAE is clearly gaining traction for the knee, but that inflammatory vascular mechanism we discussed, I mean, that could apply to a lot of soft tissue problems across the body.
It does, and we're seeing TE applied beyond the knee now.
Or else.
The shoulder is a major focus. We see TE applied successfully to adhesive capsulitis, the dreaded frozen shoulder, and also to chronic rotator cuff tears.
And the hypothesis is they share that same underlying pathophysiology.
Exactly.
Did the treatment response time vary between those two conditions?
It did, and that's a critical nugget from the literature. The speed of response is different. Patients treated for adhesive capsulitis tend to see substantial relief faster, usually within 3 months.
And for the other?
For those with a secondary stiff shoulder, it might take closer to 6 months for the maximum effect.
Okay, moving down the arm, the elbow seems like an ideal target for this kind of localized vascular disruption.
For conditions like lateral epicondylitis, tennis elbow, the results are highly impressive. One 2-year follow-up study showed the disability score for the arm, shoulder, and hand decreased dramatically.
How dramatically?
This score, which measures overall upper limb function, it dropped from an average of 50.8 at the start down to just 2.7 at 2 years.
That has near total restoration of function. That's life-changing for someone whose livelihood depends on their grip strength.
Absolutely.
What about the lower body, the hip and the ankle?
TAE has shown real efficacy for hip OA and greater trochanteric pain syndrome. One study showed a powerful WO max score reduction from 77 before the procedure down to 27 at 6 months.
And the ankle?
Specifically for plantar fasciitis, that severe chronic heel pain studies have shown significant and durable VAS improvements, with some follow-up data now extending up to 4 years.
Okay, so we have a flexible, effective, and safe procedure being applied successfully across the musculoskeletal system.
But the expert panel review wasn't all celebratory.
No, it wasn't.
They raised some serious concerns about consistency. What's the immediate road ahead for TAE?
The critical issue is the lack of standardization, or heterogeneity. The literature currently suffers from wildly different procedural techniques. Which vessels operators choose, how much they embolize.
And a lack of consistent outcome measures.
Which makes comparing studies really, really difficult.
So the research needs to catch up to the clinical results. Given that crucial finding from the Landers RCT, that complete embolization is key, what is the expert panel's sort of temporary suggestion to operators right now? Well, until we have definitive clarity from larger trials, the panel suggests that to maximize clinical success, All vessels on the target side of tenderness should be evaluated for hypervascularity and treated as necessary.
So be comprehensive.
That operational guidance stems directly from that recognition that multiple vessels are likely contributing to the overall inflammatory loop.
And what specifically do researchers need to prioritize now to really cement TAE's place in the treatment algorithm?
They need larger sample sizes, naturally,
Well, yeah.
and crucially, much longer follow-up data. Our current 4-year data is limited to only a couple of studies.
And they need to compare to the current standards.
Most importantly, yes. We need head-to-head comparison studies, pitting TAE directly against established treatments like intraarticular injections and genicular nerve ablation to accurately define where TAE works best compared to the alternatives.
We need to know where it sits in the toolkit, not just that it's a valid tool.
Precise.
So what does this all mean for you? Transarterial embolization, specifically GAE for the knee, it offers a viable, minimally invasive, and remarkably effective new pathway for patients with that difficult, mild to moderate refractory pain. It addresses the root inflammatory vascular cycle driving these chronic symptoms.
And that mechanism is the key to understanding its future. And here's the provocative thought for you to maybe explore on your own.
Okay.
While we framed TAE as this anti-inflammatory procedure that targets blood vessels, a recent prospective study measuring biomarkers found something. Well, something remarkable.
What did they find?
They analyzed several inflammatory mediators, including VEGF, before and after the procedure.
And what did they find about the long-term effect?
Only nerve growth factor was found to be significantly decreased at 12 months after the procedure.
Only nerve growth factor.
Right, so if the sustained pain relief is primarily linked to the decrease in this nerve-specific factor, then the goal might be shifting. Is the vascular pruning merely a means to an end? Is the primary long-term therapeutic effect of TAE focused less on that broad inflammation, and more specifically and potently on just stopping the body from laying down those new, painful, unmyelinated nerve fibers?
So it's not just anti-inflammatory.
It suggests that TAE might be a profoundly novel way to manage chronic nerve pain itself.